Okay, thank you very much, Laura and Aaron and Samantha, for that great presentation. We're going to move into the Q&A now. So I would invite people to submit their questions using the Q&A box, and we will direct those questions to our presenters. We have a couple already that came in during the presentation. So first being from Alzera, I'm curious to know, what is the age demographic of your clients?
So in relation to our ages that we provide the FASD clinic services for, it's for adult population only at this time. So it's 18 and above. We do not provide pediatric services at this time. Our general clinic, however, does. So I hope that helps. On average, I believe our FASD clients are between the ages of 30 to 35, I believe. Just off the top of my head. However, we have seen clients that are much older than that.
Great, thank you. Next question from Wally. In the homeless serving sector, most direct service programs helping to provide housing are based on housing first, which puts a great deal of focus on choice in housing and services, including frequency and intensity. How would you suggest these supports work with those with FASD when too many choices can often be overwhelming?
I can take that one. I would say this is where our advocates come in. They can help work with housing agencies and the various resources around the city that can help them narrow down what exactly is meant for them. So if they're having trouble taking care of themselves and taking care of their home, maybe more of an assisted living situation would be more appropriate. So the resources can work with our advocates or with the caseworkers to make sure that they're getting into the right housing places for them.
The other piece I'd add on to that question is from more of the clinical occupational therapy perspective is some of the assessments that we perform are around those adaptive behaviors and being able to cope within an environment. So from an assessment process, we can actually assess which areas of function they might need supported, and then we can give those recommendations from a housing perspective to the caseworker, to the advocate, to then provide supports in very specific areas that are individualized for that client.
Great, thank you. We have another question in the chat from Susan, wondering if your OTs and psychologists are full or part-time.
We have two at our clinic. We have one full-time occupational therapist and one full-time registered provisional psychologist. So both are full-time, and it's quite an enormous job to contribute to all the assessment process. So they wear many hats at the clinic too. So.
Great, thank you. Just a note from Marita in the chat, wonderful work that you do with individuals to support them. Folks can continue to submit questions either in the chat or the Q&A, whichever is easier. I'm wondering, I have a question while people are typing theirs in. You talked a little bit about the PDD supports. I'm wondering if you can elaborate a little bit on the nature of those supports, like the intensity and the typical duration.
Did you want to take that one, Erin? Sorry, you were muted.
Sure. As far as I know, that it is ongoing services. So they can, again, based on recommendations, they can go as little as just transporting them to the different community resources, but they can do full on, as in even in living in home supports. So it just varies based on what their needs are. I think that was.
Yeah, typically, I don't know if we touched on this in the presentation, but there needs to be an IQ score of 75 or below to be, so not all clients that are diagnosed with FASD necessarily qualify for that level of support. As we mentioned, it is a spectrum disorder. But when you look in the literature around FASD, you see a lot of ongoing supports. And so it's all about those individualized supports in certain areas and those certain brain domain dysfunctions, and providing support in those areas for long ongoing periods, like Erin mentioned. And so PDD doesn't necessarily mean a significant amount of like money supports or anything like that, but it can provide those lasting and long-term, maybe case management supports or housing supports for the long term.
Great, thank you. So a question from Brianna living in Waterloo region, and I'm not sure if you're familiar with the services outside of the province, but just generally speaking, someone looking for services, where would they start if not knowing if there are formal services in their community, or if there are, like what's usually the point of access for people looking to receive services?
So it's a hard one to determine when it's different provinces, as there's different types of supports. For us, we tend to be the first point of contact, and that's why we have sort of this overarching clinic and then have the FASD in it, because then it allows us to provide those wraparound services. That's, as Erin mentioned, the purpose of our advocates, because they help with system navigation, which can be a challenge not only for those experiencing FASD, but those experiencing poverty and homelessness in general. So I would honestly say a clinic similar to ours, or those who serve sort of the vulnerable population sector, typically would have a more comprehensive idea of how to access appropriate services depending on diagnosis or situation. Sorry, it's a bit of a nebulous answer.
Great, thank you. Next question is from David. David says, great presentation and great work. Thank you for sharing. As Laura highlighted, I can imagine that this intense assessment is very challenging for some clients to undergo. Do you find that it's preferable to try to do more on one visit, or better to break it up into multiple visits? And if the latter, what suggestions do you have for ensuring that clients come back for subsequent visits to complete the assessment?
That touches on one of the biggest challenges that we have, and maybe another nebulous answer, but it's very individualized. So it always depends on what client preferences. I always tell my clinicians now, it's all about flexibility here, because we don't necessarily know what you're going to get in a given day. You might put aside 3 hours for assessment and only get through 1 hour with the client, and then recognize some cognitive fatigue that you need to break and start again another day. However, we also have clients that maybe our location is in downtown Calgary, potentially might not like coming downtown for more than one visit, and that's either triggering or challenging for them from a transportation standpoint. And so then we'll try and accommodate as much assessment as we can in one go. So it's not necessarily a standard answer. It's very individualized for the client needs, and requires some pretty pertinent flexibility in that regard. The other area I wanted to touch on in similar in that vein is that the standardized assessment that we do administer is very, it's normed based on a very middle class sector of individuals. And so these norms don't necessarily reflect the norms of minorities, potentially Indigenous populations, because we do see a significant Indigenous population. And so these are challenges that are system-wide, not necessarily just our challenges. They're difficult to navigate, but we have to take that into consideration when we're looking at these standardized assessments and norms. And it's just something we always reflect on and have to consider. So I just wanted to touch on that as well.
Great, thank you. Next question is from Alzera again, wondering, does Mustard Seed have partnerships with emergency and or transitional shelters to advocate for getting clients diagnosed?
I'll answer this one from a sector standpoint. So our organization actually provides emergency shelters both in Calgary and Edmonton, as well as Kamloops and Red Deer. So we partner internally to recognize clients that may need to have the additional supports, but also we have really close connections with other emergency shelters here in Calgary itself. Typically people get referred to our clinic in general. They'll be flagged by physicians that work at other agencies, and those agencies often have the shelters themselves have physicians attached. So it's quite an impressive and close-knit system in terms of care providers, and I'm sure it's similar across the country. where we all work as much as possible to, create barrier-free access to services such as ours. So a lot of collaboration goes into it from a sector standpoint. Oh, sorry, Kat, I think you're muted.
Sure, thank you. Just heading over to the chat, there's a couple of questions there. This one might be similar in terms of being really individualized supports, but Karen is asking how long are supports provided to the client after the assessment has been completed?
So I'll take this one. So as far as like the clinic diagnosis process, once they're done with the FASD clinic itself, they don't have any further assessments or appointments with us unless they want to. I guess in the odd time we do get clients coming back just to follow up. Sometimes they'll meet with the psychologist to go over their assessment results more in detail. But generally speaking, they'll connect with the advocates or even with counselors and continue to see them on an ongoing basis. And that can be for as long as they need it until they don't need our services anymore. But it's really up to them to decide how much or how long that they want to access our services.
Thank you. Okay, just 2 minutes left, so we can probably get a couple last questions in. Linda's asking how your services are funded, if not through services to intellectual disabilities.
So the Mustard Seed is a charitable organization, which means that we are primarily funded on donations, which has allowed us to be quite nimble in the services that we've seen a need for in our community, and allowed us actually to open up the FASD clinic because we weren't dependent on external funding. So we're very grateful for the fact that we are donation based in a lot of ways.
Thank you. And Nicole has asked any advice on working with youth regarding impulse control.
That's a very challenging one. Absolutely. That's sort of that adaptive behavior, working with frustration tolerance potentially is something that we see frequently from the clinical assessment standpoint. It can be very challenging. I'm talking if we're working with a client that might have that and we're going through the diagnostic process with them. We have to take frequent breaks, build rapport quite well initially. Sometimes, our clinicians, this is something that we often do with any client, is that we have to really build that rapport and work with them quite frequently. From a strategy standpoint, more from an occupational therapy standpoint, it's sort of finding strategies that might support that frustration tolerance frequently. So building methods that client can use to either take a breather back from the situation and think about the situation from an executive function standpoint. So instead of moving into something without thinking it through, teaching strategies on how you can actually build in the thinking process into their line of thinking. It's not an easy one. That's more of like a treatment question and can be very challenging. We've had success working with counselors from a psychological perspective, and then also working with occupational therapists in like a treatment perspective, which isn't something that our clinic necessarily specializes in. We're primarily that assessment site, but we work collaboratively with external agencies to support ongoing treatment if needed from that perspective.
Great, thank you very much. So that is unfortunately time for today. So I just want to say again, thank you to all three of our presenters for a great informative presentation and a really great and engaging Q&A. Thank you to the audience for submitting your questions and your participation. I just want to remind everyone to please complete the session evaluation, which is located under the video player beside the discussion tab. And just a reminder that the keynote presentation from Dr. Bizzari will take place in about 15 minutes at 12:30 if you just head back to the main session. So thanks again, everyone.
Thanks very much.
Thank you, everybody. And thanks, Kat.
Thank you.